Clomid and overprescribing in the United States. Serena, this is a big topic. We've seen this in other areas of medicine. Let's start with why it's happening.
So it's happening because Clomid is very well tolerated. Clomid's been around since the 1940s. We know it has a great safety record. So very unusual to get any kind of severe complications or side effects on Clomid. The most common thing is a little bit of bloating, a little bit of hot flushes. Vast majority of the time, it's no big deal, or people don't even notice. Every once in a while, very rarely, much less than 1% of the time, you could have visual changes which are a reason to stop Clomid, because they might be actually due to vasospasm, and that's potentially dangerous, although still unlikely to be dangerous. But if you had the visual things, you would stop the Clomid right away. We would just use a different drug. It's not a big deal, but that more than 99% of the time, people just don't have any serious side effects. And it's often covered, by your prescription plan, and it's usually stocked in most corner drugstores. Like, it's just very easily accessible. And it seems like, and also when you're going through infertility and the idea of going to the doctor or going to a specialist, getting needles is, I think, very hard, very intimidating. And taking a magic pill would be like just an awesome solution if it really worked. And I think the bottom line is the data doesn't show that it's helpful for a lot of people. So most of the people that are taking Clomid because they never get their period, or they only get their period irregularly, and they have a form of polycystic ovarian syndrome, or they just don't ovulate. You take Clomid and it makes you ovulate. It takes you from infertile to fertile, because it takes you from not ovulating to ovulating. But everybody else, if you have a period every single month, whether it's 25 days or it's 35 days or it's something in between, if you have a period on a regular basis, you are ovulating. And then, so Clomid.
You don't need Clomid.
Clomid doesn't really help. It seems like
people using that sometimes
your ovulation better, but the issue is it's like 2 steps forward and 1 step backward. It seems it does make your ovulation better, but it makes your cervical mucus worse. So even if the sperm is great, it doesn't seem to get through, or at least that's what we think, Alice. The truth is, I'm going to come.
We don't have that data.
This is a confession.
Yeah, you're in my confessional.
Really, thousands and thousands of reproductive health endocrinologists and tons of studies all around the world for many, many decades. We don't really know why Clomid works. Okay, we don't really know why it's helpful. We just have these studies. We know that IUI alone, when you're having regular cycles and regular intercourse, does not improve the pregnancy rate in unexplained infertility. So unexplained is your tubes are open, you ovulate, you have regular periods, and you have sperm. So IUI alone does not work. Clomid alone does not work. The fecundity rate, the monthly pregnancy rate, exactly the same as when you take nothing and you just have intercourse at home. But for some reason, when we put Clomid and IUI together into one treatment cycle, we see a jump from the unexplained infertility fecundity rate of 1 to 2% up to almost normal, 10 to 15%. Okay, so we get, ooh, bless you.
Not COVID, promise.
Very low rate. I sneeze all the time too. I don't have coronavirus.
There's pollen. I mean, it is. It's spring. There's pollen. Wait a minute. So let me make sure I understand this. Let me get this really clear. Okay. We're talking about people with unexplained infertility when they take Clomid. So we're saying unexplained, that it really does without an IUI, there's absolutely no difference. So if your doctor, if your OBGYN recommends you try a Clomid cycle when you have unexplained infertility and you don't couple it with an IUI cycle, there is zero evidence that it really does
not seem to be helpful at all. And harmful, I've told patients this story and showed them all the data, and then some people are just like, but Dr. Chen,
I want to do it anyway.
Can I do it anyway? And
right.
It's probably not harmful. So, I've done that. And I will tell you, that's probably why it's so used, because most of the people that are doing Clomid alone for unexplained infertility are not fertility specialists. They're OBGYNs, and they don't have the ability to do IUI in their office. And the patient that is seeing their OBGYN and wants
to just do something.
Yeah, they want to do something. They don't, and they don't want to go to the specialist at that point. They don't want to see the specialist. They don't want to do an IUI. They don't want to do all that stuff. They just want to, and I guess it's a good thing because they're talking to their doctor and they're getting some advice and hopefully getting some vitamins and some other health advice and some testing. So I guess all of that is good, but the bottom line is your pregnancy rate, when you have unexplained infertility, is 1% to 2% per month without Clomid, and it's the same with
Clomid, unless you add an IUI with it. Now, let me understand this part. When we started, we addressed those with polycystic ovarian syndrome. That's not unexplained infertility.
Right, that's not explained. That's an explanation. You are not ovulating. You need to ovulate. If there's no eggs, there's no baby.
Right. So in that case, at an OBGYN setting, are they also prescribing, if they already know that the patient has PCOS, they do prescribe Clomid, that's okay.
To be with Clomid alone, there seems to be
timed intercourse.
Yeah, 80%
in that
rate.
Case,
yeah.
Oh, okay, great. 80% ovulation rate. That's incredible success to take somebody who had no confirmation of ovulation to 80%. That's incredible. Yeah. Now in that kind of setting, are they doing just timed intercourse at home with a proper ovulation tracker? Or are they coming in to do blood work to get the timing right?
Ovulation trackers don't work in this case because Clomid tends to raise the LH level. So it tends to give you a false positive.
Okay. And if you're only using an LH, what about some of the quantitative ones like an OvuSense or a Mirror Fertility or something where it's not LH?
Some of those, if you're really geeky and love checking your hormones, I think that's great. I think some people, it can be harmful because it can drive them crazy. And I feel like
they don't know if they're getting the timing right or not. And they're like, is it today? Is it today? And it's almost more stressful. They should just sort of trust the charting or not and just trust the Clomid typical cycle.
Twice a week. I think if you have sex twice a week, your husband has good sperm, then there's always a few good sperm around.
Okay.
Like, that's what they do.
They live for 5 days. Right. They live for 5 days. Right?
They're just like, they're in the tubes and they're like, where's the egg? Always looking for the egg.
That's why all the artwork shows all of them just swimming around looking. All the art's like that, right? Okay, so I like that advice though. So if you are going to do a Clomid cycle and you're with your OBGYN and you have specifically PCOS, then have intercourse twice a week as long as you already have confirmation that your partner's sperm is healthy, moving in a forward direction with no morphology issues, which means no misshapen.
The other thing is that for people who are obviously not ovulating, you don't necessarily have to check an HSG right away. You have to be aware that you could do some Clomid cycles and not get pregnant and find out later that your tubes are blocked. But if there's really low suspicion for that, and it's obvious that you're not ovulating, you could just try Clomid. And a lot of OBGYNs will do Clomid for 5 days. And then once a week, they'll check for progesterone levels so they can see, that you've ovulated. Some OBGYNs will just say, here's 3 months of Clomid, just, I'll see you in 6 months. If you're not pregnant, we'll see you back.
And you take it every day for all 3 months?
You take 1 pill a day for 5 days. And then theoretically, you really should get a period. You should ovulate in 5 to 10 days, which means you should get a period like 3 to 4 weeks later. If you don't, then you have to call and say, I didn't get a period. Maybe I need Provera,
Okay. Before we get into what Provera is, we'll do that for a different show.
I think it's better to do some ovulation monitoring with the OBGYN. And that way you have some clarity. And the other myth that's out there is, and both doctors and patients have this myth, is that more is better. So people are like if 1 pill a day didn't work, then 2 pills a day would be better, and 3 pills a day is even better.
Wow.
And the truth is the vast majority of patients will ovulate on just 1 pill a day or 2 pills a day.
Okay. So if you're not really responding to 2 pills a day, it's time to move on. Time to move on to something else. Yeah.
Because
be a specialist.
actually going higher on the dose can make you more infertile. So I've seen people that were ovulating to the lowest dose, but because they were pregnant, their doctor kept raising the dose, and it actually made their lining super thin and really shut down their mucus production. So more is not better.
Okay, I think that's incredible advice. We get a lot of questions about Clomid on the Fertility Answers app. That sounds like very sage advice that really the vast majority of people are going to have success with just 1 pill a day for that 5 days. How many months in a row should they try before moving on to a specialist if they are a good candidate, if they do have PCOS, or if they are coupling it unexplained with an IUI and Clomid?
After 2 or 3 cycles, if you're not pregnant, then you should see the specialist, get the HSG, and think about being more closely monitored. Are you really ovulating? Are you ovulating well? Is that normal?
Got it. Okay.
Do that.
Great advice. Final question with Monday Motivation. Outside of people who have unexplained infertility, is there any other classification or diagnostic area for people to avoid Clomid? Is it to be avoided if you have endometriosis or fibroids or some kind of other issue?
I will tell you, for PCO, it's very popular in the United States right now to use letrozole first, before using Clomid, because there's some recent large-scale studies that show that maybe letrozole works better. I'm not sure I totally believe it. Clomid's been around since 1940 or even before then, and and this is a relatively new study, and letrozole is relatively newer, and so there's less data. So it's an exciting study. I've been starting most of my PCOS patients on letrozole first, just because of that study, but I'm not sure there really is that difference.
Well, I think the important thing to note about letrozole, and we know this from oncofertility cases, is letrozole is very popular if you have an estrogen receptor positive breast cancer before you do a stimulation, or uterine cancer or something, when you're trying to do fertility preservation, because it mimics estrogen in the body and isn't actually estrogen in the body. So it's thought to not contribute to the growth of cancer. Did I get that correct? I'm a little out of practice on my oncofert.
Actually, Clomid is that kind of, it's a selective estrogen receptor modulator, whereas letrozole is an aromatase inhibitor.
Right.
So it stops you from making any estrogen at all. So if you were to take it long term, it can affect your bones, the health of your bones.
Right. Just like tamoxifen.
It's not dangerous, but but long term,
but in small doses,
you have to think about that. And the other thing is, because letrozole is newer than Clomid, it might be more expensive. So that's another thing, like thinking about your insurance and coverage. Clomid is just as effective, then maybe just use the Clomid if it's covered, and not the letrozole if it's not covered. I don't think there's enough of a difference to justify paying more money.
Okay.
And then the other thing is, a lot of people have this confusion about metformin or glucophage. And I've seen a lot of people use glucophage or metformin as first-line treatment for PCOS. And like letrozole have an 80% ovulation rate, and metformin and glucophage has like a 10 or 15% ovulation rate.
That's a huge difference.
Huge. But the first study with metformin and PCOS, that was done, I think, in Brazil. And that study, they had like a 60-70% ovulation rate. But then when they tried to replicate it, nobody has been able to, like, if you put all the other data together, it's really only 10 to 15% ovulation rate.
So
it's the first line of treatment is either letrozole or Clomid for PCOS. And for unexplained infertility, we like Clomid plus IUI.
The patients that we often see on the Fertility Answers app already on metformin are usually our obese patient population, and they usually already report insulin resistance.
Right.
So
because it lowers your insulin resistance. It can be used in diabetes to lower your sugar levels or control. It doesn't actually directly lower sugar levels, but it helps with sugar control.
Yes.
And, so it can help with that. And then it's a great drug to use if you're Clomid or letrozole resistant and you don't want to use injections. Adding metformin on top of Clomid can often make you respond to Clomid, which is
interesting.
Nice.
Okay. Last question, I promise. How does one know if they're resistant to Clomid? Is that a trial and error or is that a blood test?
That's a trial and error. So you start at the lowest dose, and
I see.
If you get to 3 pills a day for 5 days and you're not ovulating, then you're considered insulin resistant. And it's not related to weight or age. You really have to just
It's just a metabolic. Yeah, it's just it's just part of your whole metabolic makeup that can happen. Yeah, got it. Okay. This was incredibly helpful to your Monday motivation. Look, Clomid, a lot of controversy out there just with the level of prescriptions, but I think this is very clear that what Dr. Chen is advocating, unexplained infertility, if that is what you are facing, you should only use Clomid with an IUI and have low expectations. If you have PCOS, then Clomid is definitely a treatment option. But if you're not responding to 1 per day, weigh those risks and benefits and really encourage you to do a telehealth consult with a fertility specialist so that as you're making your decisions, you can be protective of your overall wellness and your long-term health while also deciding whether or not you should go in for an IVF treatment or a medicated IUI.
That makes a lot of sense.
All right.
Yeah, I agree.
Okay, excellent. We will see you on the Fertility Answers app. Dr. Chen's available on there. I love you, Serena. Thank you. This has been your Monday Motivation, and we'll see you next week.
Have a great
day.
Bye now.